Cold injuries today, so very common, depending on where you live. Not a lot of cold injuries here in Texas, but I've had the unfortunate privilege of being stationed in Alaska and Drum, so I've seen a lot of cold injuries there, but nothing here. But first, we'll do some check-on learnings. All right, during the mass casualty incident, while in a deployed environment, patient is pulseless with a penetrated head injury, exposed brain matter. Which of the following best describes this patient's triage category? Yeah, C. Expected. Probably a poor chance of survival. All right. 75-year-old found down in her apartment by neighbors. Obvious head trauma. When EMS arrives to assess her, she opens her eyes. When her sternum is rubbed, she withdraws to pain, is moaning. What is their GCS score?
Draw it out on a white piece of paper.
Hopefully nobody needs their calculator.
One of them.
So she opens her eyes to pain. What do we get with that? 2. Yep. Incomprehensible words. 2. Yep. And then withdraws to pain is 4. So it's 8. Yeah. So GCS 8. So what do we want to? What else do we want to do? Probably secure this patient's airway. All right. EMS brings in a 72-year-old woman to the ED after a motor vehicle accident. EMS reports the patient's initial GCS score is 12 at the scene. Seems to be deteriorating upon arrival to ED. The GCS repeated. Currently, her eyes do not open to painful or verbal stimuli. Moaning. Arms are extended away from her body. So what kind of posturing is that? Yeah, decerebrate. Her current vital signs are BP 90 over 68, RA 122, respir 16, SpO2 94%, and temp 98. What is the next step? We're managing this patient.
Problem.
Yep. Secure that airway. Oh yeah, we got one more. All right, 54-year-old male, brought to the ED after he fell off a ladder. Very common, actually. Working at BAMC, like 7 people fall off roofs a day. I never thought it would be that common. They're usually intoxicated too, and a lot of times they're construction workers. I'm like, man, you guys get to drink some beer at work. So initial vitals, 100 over 65, heart rate 120, respiratory 28. SpO2 98%, GCS 12, airways open and free from obstruction. Decreased breath sounds on the right compared to the left. Notodecumosis to the right lower anterior chest, dystrachia is midline, no JVD. And the patient is not in respiratory distress. What is the definitive treatment for this patient? Suspected diagnosis.
Okay.
I thought I heard B. Emergent thoracotomy. Not yet. Yeah, so that one's going to be A, tube thoracostomy. Oh, we got one more. 17-year-old high school cheerleader presents to the ED in status asthmaticus. Vital signs are BP 101, 65, heart rate 102, respiratory 26, SpO2 87 on 15 liters, breather despite, bronchodilators, anticholinergics, steroids, MAG. Patient continues to worsen. Which induction agent is preferred during RSI and will benefit this patient who has bronchodilator properties?
Ketamine.
Yeah, ketamine. Good. Let's say which one of those are, let's look at succinylcholine. What are some like contraindications or adverse effects with that? That way you want to think about. Like, yeah, hyperkalemia. When would I not want to use this? Yeah, crush injuries, and usually it's like a few days after. In the acute period, it's fine, but yeah, crush injuries. Anybody with, we suspect rhabdo we may want to avoid that. Anybody with like hyperkalemia, good. What are some side effects of etomidate?
Increase BP. Increased blood pressure.
No, it's like pretty neutral on blood pressure. What is a big one? It's like common board question too. Myoclonus. Yeah, I wrote a new question last semester, and I'm like, dude, this will be super easy. And I put it on, I explained myoclonus in the question, and I was like, it's super easy. They reviewed it, and we're like, yeah. And it scored like 40%, got it right. I was like, okay, I guess it wasn't that easy. But it is, yeah, it's a common side effect, and well, it's a very uncommon side effect, but it is like a board type question side effect for it. All right, there's our textbook, and we're going to talk about the different kind of spectrum of heat injuries from heat cramps, exhaustion to stroke, and then we'll talk a little bit about the same stuff, pathophys, what we can do for prevention and what emergent treatment we're looking at. But like I said, it's kind of a continuum. So our spectrum from heat cramps all the way up to heat stroke, pretty common. Not common to see deaths from it, but it is fatal. So average is like 700 a year. I don't know why 2023 was different, but I thought it was interesting that there's a couple thousand that died. I don't know, maybe everybody's AC broke or something that year. All right. So what causes this? And really, you got some sort of, your body regulates your heat, a delicate balance between your heat production, accumulation, and it dissipates it, obviously through our sweating, and we kind of dump heat. And I think I want to say we're the only thing on the planet that does that, right? I don't think any other mammal can dissipate heat or sweat like we can, which is kind of unique. But we have different, if we remember back to like science class, we have different ways to dissipate it, like and we have some pictures here to show, but radiation, conduction, convection, evaporation. Basically conduction doesn't remove heat well above 90, and then depending on the humidity outside in Texas, usually right now it's pretty horrible humidity here. And then, we don't radiate heat to the environment over 95 degrees, and we're typically, should be at, 98.7. So the normal body temperature, but it's regulated through your brain, the hypothalamus. It tries to maintain core temperature in the normal range there, so 36 to 38 Celsius-ish. And then it begins to fail on those higher temperatures and lower temperatures. So that's what we're worried about today. But our normal response is we get dilation of blood vessels, we get increased, sweat production, decreased heat production if everything's working appropriately, and we'll talk about reasons why it doesn't. And then, your body compensates, we increase heart rate, compensate for stroke volume. And then we increase our sweat production. Things we want to consider when we're looking at these heat injuries are medications that can cause this. So, anticholinergics are one that we want to consider. Diuretics certainly can cause issues, and that's something not ER related, but military medicine related. Like HCTZ or one of those medications is recommended like first line a lot for blood pressure management. Like in my practice, when I was in primary care, I would try to avoid that in like soldiers, just because we know we're going to place them in extreme hot environments. So something to think about if they're on diuretics. And then like phenothiazines, beta blockers and calcium channel blockers. And then the other ones are going to be more related to drug type situations. Or they can be on, a lot of people are on Adderall these days, so that's something to consider as well if they're out there in the heat. But we always want to consider these with any of our heat injury or cold injury cases, other secondary causes that could have brought them into the heat stress for stroke type picture. And then here's where we worry about, like elderly is very common, so that's where a lot of those deaths come from that you see there. It's like elderly people, they don't have any air conditioning. And a lot of, I'm sure you guys have lived places where you don't have air conditioning. Like when I was stationed at Fort Lewis, they still didn't have air conditioning in their housing there. I guess it doesn't get that cold there. So that was kind of interesting, especially in the summers when it's 90-some degrees and no AC. We also worry about it, like basically everything's in the young and old, right? And like basically everything affects the young and old worse. But athletes, we see this commonly in. We see it especially in the military. When we're out in the field, we don't stop training because it's 100 degrees or 104 degrees outside. And then alcoholics, obesity, the usual suspects. All right. So, and it usually makes sense, you're going to have some sort of hot environment. Physical exertion is not required, but it is going to be commonly seen in the military with like that high overexertion when they're in the field, especially during those hot training days and the 100 degrees. One, I kind of said elderly without AC is a big one. Our athletes, we want to consider it. And then that bottom one, you know, somebody, you see on the news every week, somebody leaves a kid in a car, unfortunately. All right, so here's our spectrum. We got heat edema, prickly heat, heat cramps, and then heat exhaustion followed by heat stroke. Anybody had any heat injuries in here? I would think most people have had at least some heat cramps, maybe some of that like prickly heat in here. If you haven't, you probably never like exerted yourself to the limit. No, I'm just kidding. Or you've hydrated well, unlike myself. But so this is heat edema is very common, especially in the elderly, and a lot of times you'll see it in clinic as well. If you're taking care of elderly folks, they'll say, "Oh, I get, my ankles are swelling lately," and a lot of times it'll be during those summer months, and they'll just have very mild swelling in the lower extremities. And then we worry about people who are like, anybody who comes from a colder environment down, they're not acclimated to the weather or environment. We usually don't do anything for these people. We just recommend some sort of compression stockings. You can elevate the legs, but we don't do anything for heat edema. Now, prickly heat. So this is, unfortunately irritating and annoying, but we don't do a lot for it. But you have that acute inflammation of the sweat ducts. It feels like a burning sensation. It can be quite painful. Our treatment with these is typically like antihistamines just to reduce that pruritus that the patient's going to have. And then you can do like calamine lotions, topical steroids. You'll see a lot of soldiers, if you guys ever seen them, they use hand sanitizer and like an ID card. Have you guys ever seen that? I don't know if that works or not. I haven't tried it. Mine's always like in the middle of my spine and I can't reach the area to figure it out. But you'll see this on a lot of people with body armor on, or those areas that are where you have like occlusion of those sweat ducts and they become inflamed. Big thing, like from the ER side, is just making sure they don't have a cellulitis or some sort of infection on there. And there's what it looks like. Very common in children too, especially ones who can't walk or crawl because they're laying on their back the whole time. So that's something to consider as well when we're evaluating them. And then our heat cramps. So, most commonly it starts in the calves, but then it kind of moves into those larger muscles like the thighs. Your abdomen is a common one I see heat cramps in. And usually this is from, some sort of excessive losses, typically from some strenuous activities, overexertion out in the environment. And once again, we don't do a ton for these. We really just rehydrate and make sure we rule out any like rhabdo or medication or other factors that are relating to this. Usually some sort of electrolyte deficiency is what we think causes it. We don't actually know. I think there's probably something related because you see a lot of, I've seen a lot of heat cramps and usually the patients are very well hydrated, but maybe they're not getting the electrolytes. So I see it a lot when patients aren't, they haven't actually eaten a meal or replacing those electrolytes and they're only drinking water. So maybe there's like some hyponatremic component with it. So these patients, if it's severe enough and they're sick enough, we want to get something, we may want to look at some labs on these patients, electrolytes, and then possibly ruling out rhabdo. But really the best treatment for it is going to be like oral rehydration if they can tolerate it, or if they're stable enough. So giving them some, electrolyte solution or drinks. We like to stick to PO if we can in the ER, but if it's severe, then we're going to start some sort of like lactated ringers or normal saline IV rehydration for these patients. We did I can't remember what course I was in. We did a dehydration lab though, which was interesting. So they made us it was like over 4 or 5 hours, and like one person had to drink like 2 gallons of water. We had to monitor our urine output, which is kind of weird, we're all keeping the little jugs to measure it. One person got IV fluids, and I think they received 1 to 2 liters an hour. Somebody got full Gatorade, and somebody got half Gatorade. And honestly, like I had the water one, and I felt horrible having to drink that much water. But the person who actually did the best was the one who took oral hydration with half Gatorade. It was just kind of an interesting lab. I don't think we do it anymore because it's probably dangerous. All right. Oh, where are we at? So heat stress. Some of the clinical features are going to be similar for all of these, and that's why it's kind of a spectrum. But for heat stress, they may have that headache, non-vomiting malaise, dizziness. The big thing for us is, monitoring their vital signs and then ruling out rhabdo if they're having that like kind of muscle pain. And then we want to make sure we're checking their temperature, and we want to get a core temperature on all these patients with the heat injury. So typically that's a rectal temperature for all of these. And then we want to rule out any sort of heat stroke so that they have any sort of neurologic findings along with this. Once again, heat stress is kind of like the heat cramp, so we want to start with the oral electrolytes if we can. Typically when they present at this point, we'll usually go to IV fluids when it's a little bit more severe. If we see a good response from these patients, we can bring their core temperature is not elevated over that 39, then we can discharge them if we have a good cause for this. So if they were out in the environment and we rehydrate them, that's like appropriate for discharge and their core temp's not elevated. Now if they have, we can't find a cause for it, then we may look at keeping them around in the hospital until we can address what the underlying issue is. And then here are some of the signs and symptoms. So muscle cramps, and it's kind of self-explanatory, they're going to have cramps somewhere. And then as we move on into like heat, exhaustion and stress up to stroke, you'll start to see that elevated temperature. Heat stroke, they'll have that elevated temperature over 40. And then they'll have some sort of neurologic abnormality, and that's usually mentation is probably the biggest one you're going to see affected with it. May have the nausea, vomiting associated with it. Then we can always get that orthostatic blood pressure or tilts. And then when it becomes severe, they stop sweating at that point. All right, so heat stroke, this is what we're always concerned for. So this is life-threatening injury. We want to get that core temperature on these patients, and then we need to rapidly cool them. We'll talk about the most effective cooling methods here in a moment, but this is to diagnose this, we say core temp, so over 40, so that's 104, and some sort of altered mental status on these patients. Once they've reached this point, some of them will have stopped sweating, and you can also find, they can also cause a seizure from this, so this is why we manage this aggressively. Some of our labs, big ones, making sure we rule out like a rhabdo in these patients. And then we just look at all of their blood work, so checking their electrolytes with the CMP. I don't know if I care about liver function on there, but yeah, we probably get CMP, CC. I don't know about coags, not on every patient. But we also want to look for other causes. So sometimes they can have, because of the elevated heat, they might have some sort of acute coronary syndrome, so we want to get an EKG and some of our cardiac markers on these patients. And then we do a head CT. If we don't have another cause, like if we think it's maybe a meningitis or something, we might do a lumbar puncture, or if it's subarachnoid hemorrhage, and we're not seeing anything on CT, which I think you guys covered in your earlier blocks. All right, so pre-hospital care, it's like when they're burns, like remove them from the fire first. So we want to take them out of that hot environment if we can. A lot of training locations will have like those cooling or ice sheets or ice blankets. We want to check a point of care glucose on all these patients as well, and then we want to start cooling. In the field, we don't usually have the capability to check all that unless EMS has arrived there. But some of the methods we can do, take their clothing off. We can put them into those ice chests, or if we have ice sheets. We put wet towels over the body. If we have a fan or water spray, that can be helpful as well. So we get air flowing over them to cool them down. And these patients are usually going to require IV fluids at this point, so we'll start with normal saline or lactated ringers. Evaporative cooling is what we typically do in the ER. And then we evaluate for any organ system dysfunction. So that's what we're looking at with all of the lab work that we've drawn up. And then just standard resuscitation after this. It is common to see like acute kidney injuries in these patients, common to see rhabdo as well, so we want to make sure we're evaluating for that. And the key is monitoring a core temp. So like it's easy to get a rectal temperature, but we like to have some sort of like inline monitoring it. So we have bladder, like Foley catheters that have temperature probes on them now. We have esophageal probes if they're intubated. Or you can just do repeat rectal temperatures on these patients. And we got a chart which we'll talk about the different cooling methods here in a moment. Oh, there it is. So the best cooling method is going to be that evaporative cooling. And so that's what we're typically going to use in the ER. We'll have fans out there. One of the disadvantages, you can cause shivering and worsen some of that heat injury. So it also is difficult to keep the probes on them, so we have to monitor them closely. Immersion cooling is not typically feasible in the ER. We don't have like large ice baths in there to place them in. So we typically start with that evaporative cooling. You can use as an adjunct ice packs to certain areas of the body, usually the neck, like axilla, groin. So that can be an adjunct that you add on to that evaporative cooling if needed. And then you have like more severe cases, you can look at like cardiopulmonary bypass and things like that. We don't usually use any of the, we may use cooling blankets we have in the ER, but typically we don't do any of the gastric urinary lavages. All right, so who's coming and going? Minor heat syndromes, we can likely send home if we find a cause for it. If we cannot or they have comorbidities, we're going to keep that patient in the hospital. All our heat strokes get admitted, usually to the ICU if we haven't been able to control like their hemodynamic stability. They need invasive monitoring, or if they're intubated, admitted to the ICU. There's our wet bulb right there. So what questions y'all got on this? I know it was kind of fast, but nothing? Y'all never got questions. I like it. Makes it easy. All right, let's move into the cold injuries. Y'all want a break or you good? All right, so talk about cold injuries. And really, these kind of run on a spectrum too. So we have some more minor cold injuries, cold weather injuries that we see starting with things like trench foot, moving up to frostbite and hypothermia are going to be our big ones that we're concerned for. So we'll talk about the pathophys diagnosis, where we see these the most. But cold injuries usually has to be somewhere cold, right? You can have trench foot without freezing temperatures, but the other ones are going to require some sort of freezing temperature. And the question is like, how long were they exposed? So it's a multifactorial process. Most commonly seen in like some of those exposed extremities or further distal extremities, like your hands, feet, nose, ears are common areas we see these injuries with. And then the prototypical one we always think about is that frostbite. So when do we treat it similar to burns? All right. So here's our non-freezing injuries. These are just from wet conditions. So trench foot's probably gonna be the most common. We had like a trench foot mask cowl when I was in JRCC once. It was like, maybe 40 degrees, but they wanted to like play in a swamp for days. And so we had like 30 some people with trench foot that were out of the training because they weren't wearing their boots or changing them appropriately and continue to stay wet. But usually you have some kind of factor causing their feet to be wet, whether that's from exposure, walking through swamps, or sweat. And then it was first identified in the military, which makes sense. But you can also see it with homeless, your alcoholics, people who aren't taking care of themselves well. And then the pathophysiology, so some sort of soft tissue injury, it then affects the peripheral nerve, so it can be quite painful, and it's accelerated by those like kind of cool, wet conditions. Patients are going to usually complain of like pain, numbness, tingling. You'll see on exam, they'll have that like pale mottled skin. There's different kind of phases of it. So once you start rewarming them or taking them out of that environment, you'll see that like hyperemic phase. They'll get like severe burning sensation. And same thing with frostbite too. The rewarming phase is where it becomes really the most painful. Like you can see in this patient, they have edema and bullae on there. And then these, the pain can be persistent afterwards, and they'll have sequelae sometimes permanently, unfortunately, if they stayed out there and exposed for long periods of time. And then other big things, like we always worry about cellulitis, any sort of secondary infection from this, because they're probably not in a clean environment. So we want to make sure we're evaluating for that. And then what's our treatment? Really, we don't do a lot for this. So the big thing is preventing it. So making sure they're bringing extra boots to the field, socks, clean undergarments that they can change out. And then, there are vasodilators, not very commonly used for trench foot, but really we just dryly bandage them, take them out of an exposed environment, we elevate the extremity, and then just monitor for secondary infection. All right, let's go into freezing injuries. Is anybody going to somewhere cold enough for phase 2? They don't do any like real cold place for phase 2, right? Probably won't see a lot of this. I actually had a heat stroke and hypothermia in the same JRTC rotation once. It was kind of odd. And we were from Fort Drum, so you'd think they wouldn't, the cold, they'd be acclimated to it, but they were not. So frostbite, commonly seen in activities where you're out there in the cold for long periods of time. There can be some like individual attributes. Some people maybe are more prone to it. We don't know. Some people who've had prior cold exposure can be increased risk for this. Folks with like Raynaud's may have an increased risk for this as well. What we worry about is those places that they're out there, they may not have any sort of cover or indoor areas, so wind will affect this as well. And then this has to be in some sort of freezing environment. It can develop quickly, so there's like contact frostbite. Like when I was stationed in Alaska, it was, I think I got like -60 when I was there one time, but you would get contact frostbite if you didn't wear gloves when you pumped gas. And we still didn't wear them, but we just suffered for a sec. It kind of burned. So you can get frostbite relatively quickly. And then most common on those distal areas and exposed areas. So I think the nose is probably the most common. We would see it when I was in Alaska, and then followed by like hands and feet. All right, so this is going to be some sort of freezing injury. So it's tissue, some sort of tissue or distal area is going to become frozen, and then it's typically not as severe while it's still frozen. It's when we start thawing that it contributes to the degree of injury. And it's similar to how a burn is. So we think the thawing is what causes a lot of this endothelial damage. And one of the big things is making sure we're not, we take them out of that environment before we start rewarming these patients. But it eventually leads to, ischemia, necrosis, gangrene. And it can be pretty severe. You can lose limbs from this, which we have some great pictures of. Frostbite injuries are categorized, like we'll talk about this during burns as well. I think surgery talks about it too. So we have, our most severe area. That's going to be our zone of coagulation. And so this is going to be irreversible damage. We have our zone of hyperemia, which may or may not be reversible, but usually it's a little bit more superficial. And then our zone of stasis. Sorry, I mixed it up. Zone of stasis is the middle ground. Sorry. And then the most superficial is zone of hyperemia. So zone of stasis may be reversible or it may not. And we kind of categorize them. We lean on the side of more severe for caution. But here's our different classifications, and we'll kind of go through these. But first degree is just kind of similar to a burn. You see some areas of redness, maybe some central pallor. Patient complains of numbness. You might see edema in that area, but you're not going to see any blisters with a first degree. Second degree is when you start to see that blistering of the skin, like significant erythema and edema. And then third degree is when we start to worry about tissue loss. They'll have hemorrhagic blisters. And then fourth degree is just the entire limb or wherever the digit, wherever it is affected. And that one's typically going to have to be removed or amputated. So first degree, that's just partial skin freezing. Some, we used to call it frost nip, or some people still call it frost nip. But really, it's like a burn. You got that erythema of the area, so you see the redness, some mild edema, blistering. There might be some desquamation in the skin, and the patient will complain of like stinging and burning. This is a great prognosis, just like with a first degree burn. Prognosis is excellent. They'll heal well on their own, just usually with conservative therapy. Then as we move to second degree, that's full thickness skin freezing. So you'll see significant edema, erythema. This is when it starts to blister. So you'll get like blisters, you'll see some desquamation with this. And then sometimes they can form like black ash scar on there. Patients will usually complain of like numbness. And then as we re-warm, they'll start to get that like aching, throbbing, more severe pain. Second degree are still managed really well, like good prognosis, just like our first degree burns. And similar to, we categorize our like actual burn patients, like thermal burns, similarly like superficial second degree heal well, but deep partial is usually worse. And it's kind of similar here until we move into the third degree. But here are some pictures, so you can see that like the edema on there. It looks like there's maybe some mola on there. I don't know if I see it, but you got that significant edema. And then here's our third degree. So this is when it goes into the subdermal plexus. You'll get hemorrhagic blisters on these patients. You'll see that skin necrosis, like discoloration of the skin turning blue to gray. Patient might say it feels like a block of wood. So this is usually going to be frozen or close to frozen in these environments when they have it. And then they might have some like burning, throbbing. This is a very poor prognosis. These are patients that are likely going to have to go to a burn center. A burn center will manage some of these higher degrees of frostbite, and they'll likely have to have multiple procedures, and a lot of times they'll lose some of that extremity. So you can see how it's a little bit more significant than our second degree frostbite. And then our fourth degree is going to be the worst. So this is basically everything's frozen, kind of like burns as well. When you get that severe fourth degree, it goes all the way down to the muscle, tendon, bone. They may not look as impressive initially, but as you start to rewarm them, you see the significant symptoms start to present, or significant findings on exam start to present. So they'll have that deep, dry, like mummified scar on there. And there's some pretty nasty looking pictures of frostbite. And that's a common location, like on the feet and toes, that you're going to see. So this patient's going to have to go to a burn center. They'll have to do multiple procedures on these, hopefully attempting to save the limb, but likely not. And there's a pretty unfortunate picture. That's going to be your fourth degree. And then the one on the left is a month after injury. And then the other one is, 2 months after the injury, so you'll likely lose that digit or limb. So frostbite's clinical diagnosis. Like I said, usually distal extremities, somewhere on the face, nose, ears are where we most often consider this at. You might see some, they might present, with just superficial injuries or maybe deep. So we would do a thorough evaluation on them. There's no great lab tests that we're going to run for these patients. I've never seen a technetium 99 scan on these patients, but maybe some places that manage frostbite a lot more often are doing it. We can use like angiograms after we initially rewarm them, just to look at the vasculature and see how effective the vasculature is, if they still have distal perfusion going to that extremity, which would be a good for prognostic findings, and maybe we can save that limb. Key things for our treatment, especially like pre-hospital phase, is because we get a lot of those injuries when we start rewarming, we want to make sure that we get them out of that environment first. So if we can't do that, then we don't want to rewarm those extremities. So don't thaw them until, refreezing can be eliminated. And this is, more on the EMS side, but it's something you think about in the field, which is why usually when you're out there training, you guys will have some sort of warming area or warming tent for the medical folks so that they can treat this, hopefully. And then once they get to the ED, rapid rewarming is going to be our most effective and first definitive step. So these ones, circulating water bath is going to be something that we commonly will use for these patients. We always want to think about that life-saving tetanus immunization because they can get tetanus caused from these from an infection as well. And then pain control is going to be paramount. So these patients are going to be in significant pain once we start that rewarming. So opioids are going to be very commonly used in these patients. And then we elevate the limbs. All right. So here's some of our treatment algorithms or core treatment. So immersion or some application of warm water on these patients until it's viable erythematous. Once again, don't start it until the refreezing risk has decreased. Usually some IV narcotics are going to be our mainstay of pain control. And then you can do some topical therapies like aloe vera. We don't typically debride anything like the blisters during this acute phase, and we just monitor for any signs of infection. Make sure their tetanus is updated. Anti-inflammatories work well for these two to help reduce some of that inflammation. And then we want to make sure we're evaluating those extremities after rewarming, looking for any sort of neurovascular injury that they may have from it. Most of these patients are going to be, especially the 3rd to 4th degree, are going to be admitted to the hospital. So most of our treatment or the core is going to be limited to that core treatment. And then once those patients get admitted, they'll look at, depending on the protocol and where they're at. So like the intra-arterial thrombolytics should be something like, you'll see it more commonly at like a burn center because we transfer a lot of these patients to burn centers. There's also other medications like they can do iloprost where it's available. I've never used it, but it is something that can be used for treatment. Most frostbite cases, the 1st degree likely will be discharged. Sometimes 2nd degree we'll be able to discharge as well, as long as we've evaluated them during the rewarming phase and we're not suspecting any deeper tissue injury. We want to make sure we're giving them good pain control if we're sending anybody home, but any 3rd or 4th degree we're going to transfer to a burn center. Then we want to tell them to avoid smoking, alcohol, anything that really is like a vasoconstrictor we're wanting to avoid in these patients. All right, hypothermia. So this is a body, core body temp under 95 or 35 Celsius. Not always seen in cold climates, but more common in that cold environments or depending on where you're stationed, you may or may not see this more frequently. And then we want to think about secondary causes from impaired thermoregulation, which can be comorbidities, medications, drugs, things like that are something we want to consider. And then here's some of our causes for secondary. So this is like burns. That's why we want to make sure we're monitoring our burns thoroughly for their core temperature, because they can lose. Your skin is what helps you regulate all of that heat, and so if you take away that function, you can run the risk of hypothermia. So it's something we always want to monitor closely in our burn patients. And then we got to think about other reasons we can cause this. So sometimes if we're given cold transfusions, that's why we're monitoring for that hypothermia, or we're packaging our patient really well so we can avoid that lethal triad for our trauma. And then, you can have, that impaired thermogenesis from like shivering, things like that. Then there are a lot of different medications that can contribute to a hypothermia. All right, so here's our pathophys. And like I said earlier, you got, a lot of those work for us, like for our heat loss when in a hot environment. But we have conduction, convection, and conduction can be used like something that the patient, is touching, so it's direct contact with that cold object can cause this. Convection would be usually air or water over the patient, and then we have evaporation and radiation. Our goal is going to be to try to minimize that heat loss once we're managing them, so we want to remove wet clothes, we want to dry the patient, give them some insulation. We have some great tools we can use in the hospital, like our bear huggers, which I think we have a picture here, which will explain it better. But there's our cardiorespiratory response. So we start to get like peripheral vasoconstriction. We'll see a decrease in our heart rate in these patients, blood pressure, myocardial contractility. And then as we progress, as we get colder, then we run the risk of arrhythmias, so we might see some sort of dysrhythmia like AFib, VFib, things like that. So that's we have to start monitoring them very closely once, based on our ACLS algorithm, once they get colder. And then we'll show our classic Osborne wave, but really what we see is that like prolonging on our EKG of our PR and our QRS waves, QTC. And there's that Osborne J wave that is seen with hypothermia. So if it's there, that's something that can be helpful when we get an EKG. And this one has AFib with it, so it's like normally you see a faster response with AFib, but this one's pretty slow ventricular response, which is consistent with hypothermia. All right, so, other issues we can have, other pathophysiology, we want to consider like rhabdo can affect this. Do they have any sort of coagulopathy? And then our main concern is going to be once they reach that lower temperature, especially below 90. A lot of times, have you guys ever heard like we don't, the patient's not dead until they're warm and dead? So when we're resuscitating a lot of these patients, if we get a core temperature that low, we want to rewarm them first before we discontinue our ACLS or CPR and call the patient dead. But clinical features, they got a low body temperature, so we want to get a core temperature. So, rectal temperature is probably going to be our best one initially until we get invasive monitoring. And the patient will feel cold to the touch. As it progresses or they worsen, they'll start to have like altered mental status. They'll see vital sign changes on there. So anybody we suspect this in, we're getting a core temp immediately when they present. And then a lot of times, the lower the temp, they might be altered, unconscious. Like it says, if they don't have a low temp, typically they're not unconscious till like below, or altered, I should say, till they're more below like that 90-degree mark. So if they're not, then we may want to think about another cause for these patients. And then I think it's a little small on there. Let me see if we have it broken down. I think we do. All right, so here's kind of our staging and treatment of the accidental hypothermia. So, you'll initially, like from 35 to 32, they'll usually just be conscious, shivering, and then we just provide a warm environment. The big thing, making sure we're taking off any wet clothing. We can give them warm fluids. We'll recommend them to like move around to get that blood flowing. And we just want to rule out any sort of secondary causes at this point. And as you progress lower, especially that like below that 90-degree mark, that's when they start to get like altered and impaired consciousness. So that's when it becomes a little more concerning. That's when we start our active like external rewarming. So we can use warm blankets. We have heating blankets. We have like what we call a bear hugger in the ER. So it's basically a blanket with tubes, and we shoot warm air into it from a machine that we can use at the bedside. So that's when we would start, utilizing our bear hugger in these patients. But we want to make sure we have them on monitor. We're checking for any arrhythmias at that point. Getting EKG, we might see that Osborne wave or J wave on there. And as it becomes more severe, that's when we see the unconsciousness, the vital signs start to decrease. Once we hit that severe stage 3 portion, and this is when we're usually moving into like our ACLS algorithm, because they may not have vital signs on initial presentation. And we need to consider other things like we can have the ECLS, so that's more like the ECMO realm. Only in certain facilities they're going to have that, which BAMC does, but a lot of places don't. And then once we progress to 4, that's just cardiac arrest. We're doing our ACLS algorithm and rewarming them if we have a core temperature and we suspect this hypothermia. All right. So not all devices can measure that low of the temperature. So most of the ones in the hospitals are going to go that low, so we don't usually have to worry about it. But it is something to think about in your like sets and kits that you have thermometers that can actually read that low. Intubated patients, we can use like more invasive monitoring. So you can have an esophageal probe in there. We can do like a rectal or bladder probe as well. But we want to avoid any oral or tympanic membrane temperature measurements to diagnosis. You'll see this a lot actually in intoxicated patients. We also want to consider it with sepsis. If we see it with sepsis, it's usually a pretty significant finding. Requires aggressive management. Consider DKA, any of those other secondary causes in these patients. And like I said, nobody's dead until they're warm and dead, so we're not going to call the code until we've rewarmed that patient back to a normal body temperature. And if at that point we are still not seeing any vital signs or PEA, then we might call it. But big things, getting that point of care glucose, getting EKG, may or may not get a chest x-ray. And then once again, any cardiac arrest, we manage that with our ACLS protocols. And there's general treatment principles. So obviously the severe ones, we're doing our ACLS, BLS, so CPR in those patients. We're rewarming them. We want to prevent any further heat loss, and then rule out these secondary hypothermia causes and transport them if they're not at a facility that can handle this. All right, so what do we see in the, so it was kind of in that box earlier, but when it's mild, they're, should be conscious, they're still shivering. These are, have a good outcome normally, and we just rewarm them. So put them in a dry place, put a warming blanket on them, give them some warm drinks. We can recommend them to move. If there's any secondary causes, we need to rule those out, like trauma or significant comorbidities, burns. We want to consider those, and then as we progress throughout the stages, they start getting impaired consciousness. They may still be shivering in stage 2, but as that temperature progresses below 90, you'll start to see that loss of consciousness or impaired consciousness. For stage 2, we're still, we're going to rewarm them just a little bit more invasively, so if they may get the warm water baths. We'll have on a bear hugger. Anything we can do to increase that core body temperature. If you're giving fluids, make sure they're warmed, and then we need to monitor once they're this low for any arrhythmias. So, do I see any flutter, fib? There's what a bear hugger looks like, or some of our minimally invasive. So it's like a blanket we place on there that shoots some air through it. If you're in a pre-hospital environment, then you want to get them in, some sort of sleeping bag if you have it. What else do they say? Like you got body heat, so I don't think I'm going to get in there with them as the provider, but maybe one of your medics can do it. Who wants to volunteer? All right, so once you hit that stage 3, they're going to be unconscious. They should still have vital signs at this point. We want to make sure we're monitoring that core temperature. You can see on the picture that's like a ECLS patient, so that's going to be like your more advanced life support. So they can. Anybody ever seen ECMO? Yeah, I won't get too into it, but really, they can bypass a lot of your body systems, whether it's your lung, your heart, and it's kind of like cardio bypass, but it's can be used for lungs, it can be used for heart, and really they have machines next to it that regulate all the oxygen in your blood, and they can be used for venous versus arterial, so it's pretty advanced and fancy. If you've ever seen it done, they put like literally a garden hose in people. The lines are so huge, so it's pretty significant. procedure when they do it. But that can be considered if you're at an ECMO facility or ECLS facility for these patients. And then once they're stage 4, this is going to be cardiac arrest. This is going to be done, our ACLS, CPR. We're going to try to actively rewarm them as well. We want to make sure we're giving warmed IV fluids if we're given anything. And then for post-ROSC management, typically we rewarm to that 32. And hypothermia, most of them are going to be admitted to the hospital. Now, if you have just like a stage 1, you've found the cause, you've taken them out of the environment, then that's something you can likely discharge. But anybody that's higher, like 2, 3, and 4 are going to be admitted. We want to make sure we rule out any secondary causes for these patients. If we discharge, we want to make sure they have close follow-up with their primary doctor or whoever they see. And once again, special consideration. So the young are always ones we worry about. So children, we need to talk to some sort of consult with some pediatric expert unless we've identified the cause in these patients, moved them out of the environment. Typically, when especially infants or hypothermic, that's usually significant. We have to figure out what's causing it. So is it a lot of times you see with sepsis or some sort of infection? It usually portends a poor outcome and needs more aggressive management. And then if you can transfer to like ECMO, ECLS facility, if you have the availability, great. All right, I know that was fast. You guys got any question? No? Usually not. What do y'all got after this?
Surgery.
Oh. All right.